Good evening and welcome to this yet another session of LGS operative surgery, and we are continuing a series on anastomosis. We have heard, we had two sessions on bowel anastomosis and one other session on vascular anastomosis. This is the second of the three sessions on vascular anastomosis, and to give us an insight and give us a minute by minute sequence of how to go about doing a vascular anastomosis is none other than Dr. Ilango Sethu, who is a senior consultant hepatopancreatic biliary and transplant surgery at Chennai, and is also one of the moderators of Learning General Surgery. Welcome, Ilango, and over to you.
Thank you, sir. Welcome everyone to one more session of anastomosis. We did a session in the last week about the basics of vascular anastomosis. Today we have made videos for your learning from the LGS side about 3 methods of end-to-side anastomosis, which may be useful for every one of you. Okay, just to run through the basics of what we discussed last time. As general surgeons, it's very important for you to know how to handle blood vessels, because bleeding happens to be a very common intraoperative event. And we all recognize that all vessels cannot simply be ligated. Now, repair or restoration of discontinuity keeps the blood flow to vital structures. So you must know how to reconstruct blood vessels to become a complete surgeon. Now, vascular surgery, I always teach, is the last component of good visceral surgery. Either you're doing GI related work, urology related work, oncosurgery related work. This vascular surgery is a component which will enable you to take your level of surgical practice to the next level. Now, a few things we discussed last time. You always should remember Professor GDS's post on getting your vascular clamps before your first card. So this is a very, very, very important lesson for all of you when you step out for practice as an independent surgeon. But I also add a few things that, in addition to what Professor GDS says. You should buy a surgical loop. I think the basic loop for a surgeon is 2.5 times magnification. And the third part is having sterile vessel loops in your own car or whatever you have, cheap and reusable stuff. And lastly, what I have learned from practice is because these events will happen in unprepared circumstances in hospitals where you may not have skilled nursing facilities. So you must know how to prepare heparinized saline for every vascular anastomosis. The simplest method is to put 5,000 units in 500 ml of normal saline, and you've got good heparinized saline at 10 units per ml. So that'll be very useful to wash the anastomosis. So we do anastomosis between many structures. What is exactly different in a vascular anastomosis? Now, these blood vessels are extremely sensitive to trauma. If you make a mistake, it will induce undesired thrombogenic activity on the intimal surface. So as I tell this, today we had a renal transplant, a 4 mm renal artery. Halfway through the ureteric anastomosis, we found that the kidney became soft. We did the Doppler, the flow was inadequate. We explanted the kidney, checked, and found a clot inside the renal artery. And we pulled out and we corrected it. The flow completely reversed. So even small undesired thrombogenic activity can precipitate a large thrombus, leading to organ dysfunction. So vascular structure is a structure of separated wall layers. You make a small mistake, you will dissect the intima from the media. This can produce something what is called a dissection and can lead to ultimately to occlusion. We also discussed virtuous triad. So the 3 parts of the virtuous triad, which leads to thrombosis: stasis, vessel wall injury, and hypercoagulability. The 2 parts, stasis and vessel wall injury, are still under the control of the surgeon. So you should never injure the vessel wall. There's a tendency for people to twist the vessel wall for convenience. So you should never do that. You have to flow with the needle. You must never move the vessel unnecessarily. You have to practice gentleness. You have to take a good bite of the intima. It should include all the layers of tissue. Now, stasis, sometimes when you create narrowing on abnormal angles, there will be eddy currents that are created within the vascular system. So your aim, a surgical aim, should be to appropriately adjust the flow so that there is a reduction in the eddy current and it will ensure good flow. Now, hypercoagulability is one place which is a medical issue. So today we were giving cryoprecipitate. We think that's the one which precipitated the thrombosis. So these are things which we are not able to control, but I think as you become senior enough, you will be able to control those factors as well to give a good result for your patient. Now, okay, this is from the last one. So introducing vascular surgery, you have to know a few things: bulldogs, clamps, needle holders, ability to handle fine sutures and heparin. You have to master these 5 components to help you be prepared to do a good anastomosis in emergency circumstances. Now, what I tell everybody is that there are only 2 simple components of a successful vascular anastomosis: orient the vessel properly, approximate the intima. Just very simple rules. If you follow these 2 things, you will have good success. Now, this is a magnification loop, which I am using on a day-to-day basis. It comes from Oroscoptic. It's called a fixed lens system. That means the lens is fixed to your glasses. You cannot adjust them. It is custom made for the surgeon. Rarely you can use other people's, but that's very rare. It is custom made for your interpupillary distance so that it's perfect when you wear it. Now, 2.5 times magnification is the magnification that is good for general use, meaning that you can do hernia surgeries with that. You can do any kind of surgeries with a 2.5 magnification up to a liver transplant. The cost is roughly about 1.5 lakhs, but it lasts for 10 to 15 years. So it gives good number of years. If you do regular vascular work, or sometimes if you're pediatric surgeons doing pediatric open surgeries, it is good to invest in higher magnifications. Now, the one shown in the picture has a 3x, 4x, and a 5x magnification. And I also possess a 5.5. The view is phenomenal. Its view is phenomenal. But what you should understand is that as your magnification increases, your field width and the field depth is narrowed to a small cube. So that is the mastery you have to learn when you're handling the loop. It's good to go with a simple one. 3x itself is still larger, but I think you can manage a 10 centimeter cube in your work at a regular time. And the view, as I said, is phenomenal under the loop. So invest in one. Now, these are the basic clamps which I normally recommend. A pediatric Castandra is shown on one side and a selection of Satinskis. You must also learn how to use a Rimmel tourniquet. So last time we discussed, I hope it's seen on the video, I brought some instruments with me. I've just simply put the what's commonly used. I hope this is visible.
Yeah, you bring it a little down. Yeah, that's fine.
Yeah. This is a Castrovage needle holder. This one is custom made for me. So I had it made by a local manufacturer. It's a 9 inches. This is for renal transplant. So Castrovage needle holder has a small locking system. The biggest advantage is that it does not have a ring. So it's easier for one to rotate it very easily with your hand. And it has got a pen grip with which you can follow the anastomosis is much more easier to do. Very delicate movement. The finger movement alone will give you a 360-degree rotation, just the finger movement alone. It requires a little bit of practice for you to learn how to use a Castrovage, but once you start using it, it's an addiction. So now in the way you hold the Castrovage varies with the depth of the surgery. If you're doing something on the surface, you can hold it pretty close to the tip. But as like in renal transplants, when you're operating in a depth, sometimes you may need to hold it like this so that the instrument will still be under your control, and you need a little bit of strength in your fingers for that, but it comes with practice. The second key instrument that we use is Gerald forceps. This again is custom made for us. This again is 9 inches. The Gerald has a small tip at as a very narrow tip. It can hold up to 60 sutures very easily. Anything less than that, we use a ring tip. I don't have a ring tip with me all the time. And I carry 3 or 4 such Gerald forceps with me. This Gerald sometimes comes with a DeBakey tip, in which you will have 3 serrations on one side and 2 on the other. They are for vascular grips. The other one is a simple one. Both are good. So the other option of you, for you to do a good vascular surgery is this good instrument. This is a regular, looks like a regular needle holder. But if you look at the tip, the one before the last, it's called a rider forceps. Rider forceps works like your regular needle holder. So the rider needle holder works just like your regular needle holder, but it's so thin, it can hold fine needles like RB1, which is about 13 millimeter. RB1 is about 17 millimeter, RB2 is 13 millimeter. So you have a much more good control of the smaller needles which you may require in practice. So these are the basic instrument sets that I normally recommend. So what kind of sutures you should have? The general rule is that 50 serves most of your purposes, especially when you're in general surgery, trauma, in an emergency circumstances. 50 is the suture for all of you to use. So I have given on the right side aorta, above knee and below knee. If you go below the knee, smaller vessels, 60 is good. Above knee, up to the level of the aorta, that is before the common iliacs, 50 is good. In the aorta, 40 is the best suture. So for Indian patients, I've always seen that you may need one size less. But that's what I have given as a correction, okay? In US, we used to suture the vena cava with 3 zeros. Here we use 4 zeros. So one size less for Indians, probably because we are a little petite. So this is what we are going to focus today. This is renal transplant. It's a classical end to side anastomosis. Today we are going to see 3 such anastomoses. So first we are going to see the 2-person method. It's a video which runs for 70 minutes. You can please stop me if you want me to pause or rewind. Okay, I'm going to stop this slide share and I'm going to share another piece. All right, is my screen visible?
Yeah.
Yeah, perfect. So to do a 2-person anastomosis, what I have done is there is a longitudinal opening and I have put 2 stage sutures to keep the opening like like 2 triangles placed on the base. Okay, so a rhomboid shape. Okay, let me start playing this. So I want you to watch how I hold the needle. I have forward loaded it, meaning that it's projecting slightly on the anterior side. It's easier for me to handle. Just follow it up. We are using a Castro and the same instruments which I described. That one is a thin DeBakey. We didn't have a Gerald in the lab where we recorded this. A simple suture inside out. That's the first one. We call this a north side suture when it is towards the head. So it's just a terminology which we developed for us to understand easily and communicate with each other. So I will stick to this. A north side suture inside out is the first step. Now you bring the next vessel, which is to be anastomosed. And watch me, I'm holding it very gently. And you get the, okay. This is in a lab, probably may not happen in a regular life. All right, so all sutures are taken inside out. So watch me how I change the needle. It's a very, very simple technique. I'm just going to go a couple of seconds before. It's good for you to learn that technique of rotating the needle, okay? So watch how the needle adjusts, is gentle, holding on the tip, and a tilting, you will get the backhand loaded very quickly. All this requires a bit of practice, okay? So I hope these videos are clear for you to understand. Audience, anybody from the audience?
Very clear, Ilango, very clear.
Thank you. So we are using the aorta from the beef aorta. So these are good vessels for you to learn how to practice. So pull both the sides and throw 3 good knots. The 3 good knots is, the first one is a squared knot. The second one is not a squared, is a reef knot. And the third one, again, a square knot. So 3 good knots. Sometimes if you're not getting the squaring properly, it's good for you to throw 4 knots. So otherwise, I'll show you what will happen. Okay. So I'm throwing 3 good knots on the northern side. Okay. So for you to understand, we have just pulled up so that you can see how the knot is placed. Now, this is what will happen if you're going to place a knot or a reef knot on the first throw. So just watch this. This is for your learning. This is so that you can understand your mistake. So this is a slip knot having difficulty. You saw the ease with which the first one fell down. First one was placed. Okay. So 3 knots, but the first one was a slip knot. Okay. So we're starting the anastomosis. I have a good colleague who's assisting me on the other side.
Ilango, there's a question from the audience: is what material are you using for suture in this practice?
So I am actually using 5-O-proline.
5-O-proline.
6-O-proline. We are using 6-O-proline. We are using 6-O-proline so that it's easier for everyone. All right. Okay. Let's play. So hold the adventitia. That's how you hold the blood vessel. So he's going to show you. The first bite is always there. The bite next to the corner is always taken in 2s, meaning that you go from outside to in, then reload the needle again. You have to take it at an angle. So you have to take it out so that the knot is carefully placed. Okay.
If you can see the question in the question box.
I can, sir. So how are you suturing both corners together? I couldn't get that. Yeah, if the bite is taken through the intima, won't it cause thrombus formation? Now the idea is to approximate intima to intima. It does not cause thrombus formation. I think the thrombogenic potential of proline suture is quite minimal. You have to take it through the intima. Okay, so now watch how each bite is taken. So now he's holding this suture. This is what I want you to learn. Hold the vessel by its adventitia always. Sometimes this is quite easy for you to hold the vessel and stabilize it in the younger days. But if you do it on a deceased intima, the intima will crack. So it's good for you to learn even in healthy, good vessels, not to hold the intima. So just to hold the adventitia. If you have to hold the whole vessel, do it extremely gently. Otherwise, the intima will crack. We've got one more question. I want you to watch, Dr. Harun. Just watch the whole video, you'll get it. So these are evenly placed sutures. Okay. Now you see how my colleague places the sutures exactly precisely at an equidistance. So that will actually prevent the bleeding from happening most of the time. It is not the number of sutures you place, but the equidistant distance between the sutures, that is very, very important. So now what we do is halfway through the wall, we stop. This is placed under tension using a shot. And he's preparing the next suture. So he's going to start from the other end. Again. Okay. He's going to take it in 2. He's loading it. You can see a small traction on a slip knot has allowed the suture to come apart. So that is why your first knot should be always squared. Okay. So we wanted you to learn this. We wanted you to learn this. Obviously, we are able to tighten it now, but in the field, it's very difficult. So one should learn how to square your knots very, very well. You can take a little bit of time because vascular anastomosis in general surgery is not time dependent like transplant, how we do. So you can always take a time to square your first knot so that your knot sits secure. So again, you could see him taking it perfectly to equidistant from each other. There is a certain way of assisting in a vascular anastomosis. Is to always splay the edges so that your colleague gets the right bites. You should see where I have pulled the suture. And normally in a GI anastomosis, we don't let go of the suture. In vascular anastomosis, as soon as the surgeon has control of the needle, you have to let go of the suture so that the suture hole, needle hole does not become larger. Sorry. Okay. So watch how he finishes. That's the most important part. He's going to finish his side. There are a couple of questions here as it is running. What is the material mimicking vessels in this video? It's the aorta of from the cow. Okay, we did it in Johnson & Johnson's lab. in Chennai. And they were kind enough to lend to us 2 of these vessels, preserved vessels. So it's not a mimicking material. It is the actual aorta of a bull. Now, the second question, Tawid Ahmed, to everyone is that, can we place the corner sutures in a regular way, like outside in and then inside out? So, like I told you, in a normal, healthy vessel, you will get away with it. But if you have a bad vessel, sometimes if you take your suture from outside to in, the intima may separate from the media. So that is why you should always tack the intima first. So that is the key for you to learn. Got it? So one side of a 2% anastomosis is complete. This is how we regularly do our renal vein anastomosis. Regularly. 1% completes the anastomosis. Now you can see how enlarged we are. This is a macro video. So you're seeing a very small vessel enlarged quite back. So you're able to see the inside of the anastomosis. I hope it's clear. Okay. So all the intima is completely approximated. So you watch, you don't need a beauty. You need the intimal approximation at all times for a successful vascular anastomosis. My colleague has beautifully demonstrated it. So now, again, from this side, you're watching how the suturing is completed. So learn how to load your needle in the tissue. So we have a small problem. We have pinned the vessel on either side. So
Pari, you have any comments to make?
I just entered, sir.
Okay.
So I'm just watching.
Yeah.
Sorry, I was late. I just got in.
So, hello, Pari.
Hi, Ilango. How are you?
I'm good. I'm good. So always the corner is taken in 2. And like a spoke in a wheel, so I'm taking a slightly bigger bite. It actually does not matter. A lot of people take thin bites. I think Pari takes thin bites. I'm used to taking thicker bites. This looks really big, but the vessels are quite small vessels. And because it's a macro video, videography, you are able to see the detail. So watch. It's just like a simple running suture, as long as you approximate the intima to intima. The number of sutures actually does not matter, as long as it's equidistant. And so the reason why we put the stay on the other side also is to avoid backwalling the anastomosis. A little bit of practice, you will avoid them. But in the initial phases, it's good for you to watch and take every bite under vision. Sorry, in the human body, we never do this, but we were using a lot of proline suture material, so we didn't want to waste the anastomosis, the suture material, so we had to pull it off the tissue. Normally, we cut the thread, and you can pull off both the needles. So go at right angles inside. Again, take it in 2s. There's a slight technique which we could not demonstrate in this portion, is when you do an end-to-side anastomosis, the cut on the side of the blood vessel should be slightly more. It's about 10% more than your vessel diameter. So that there's a slight splaying of the vessel, just like in a natural situation. So that will give you a much better anastomosis and more secure anastomosis. Pari, can you do me a favor?
Sure. Tell me.
Pari, can you moderate the chat box for us?
Okay.
Okay.
Sure.
Thanks. Videographer was quite impressive. So he took a macro. It's a very tiny thread, and he was able to demonstrate every bit of it. We really loved demonstrating this for you.
Ilango, there is a question from Dr. Narendra.
Okay.
I think it's a very relevant question. He is asking, what is the distance between each bite, and does it vary for the vessel size?
There is absolutely no need for you to worry about the distance between the sutures as long as it's equidistant. Of course, you should not put it like too few, just adequate number. There is no specific number for that. The only difference between the vessels is that when you suture blood vessels like aorta, it's good for you to cross both the sutures on either side and then tie it. Pari, you have anything to add on that?
I guess the question, maybe what he meant was, is it distance between each bite, or how thick the bite should be? Maybe, what is your answer about how thick the bite should be? Does it vary for the vessels?
Absolutely not. The most important thing is stacking the intima. So the depth does not matter. See, there are lots of colleagues who take thin bites. I've seen both vascular surgeons and transplant surgeons. I think Pari, you still take thin bites, isn't it?
I take very thin bites, yeah.
He takes very thin bites. So when I learned the vascular anastomosis, the most important thing is not to miss the intima so that a dissection is initiated. So we were taught to take slightly thicker bites. What you're seeing as thick bites is actually very thin on the field. You're seeing an extremely magnified view of the anastomosis. Last time when we put the video, you're not able to see. This will be like the good bite will be about 3 to 5 needle tips is what is the rough one. So that's what I would suggest. So we saw the first part of the anastomosis. Okay. This one is the 2% method. I'm going to show you something which I'm very, very fond of. This is called the Telus method. Anything in between? If there are any questions to be answered?
Yeah, I think there is one more relevant question here. Dr. Tawheed Ahmad, he's asking, we are taking all other running sutures from outside in. Is there a possibility of intima separation in these sutures as well? I don't know whether this has been already answered because I just joined in late.
The first few ones we did that. All that. That's actually a very good question. In a deceased, you have to choose which one is the least diseased vessel. The least diseased vessel, you can go from outside to in, that is from adventitia to intima. And on the more diseased vessel, the atherosclerotic vessel, you have to go from inside out. Suppose you have 2 bad vessels, I would do it interrupted and I would take all the bites from within. Like when we do on small vessels in liver transplantation, and we want to be very sure, we take them individually, interrupted sutures. This, what we're teaching you, is a continuous suturing method. Relatively healthy vessels, but if the vessels are unhealthy, it's good to take intima on both the sides, inside out, and do interrupted anastomosis. Pari, anything you want to add?
Yeah, only thing I would add is, if the vessels are looking bad on either sides, yes, it has to be both sides inside out, like Ilango said, and then you may choose to take a needle which is called CC, that is calcified coronary needles. They look black in color and they are very, very sharp. So when you have a very bad calcified vessels, these needles are extra sharp and they are very special needles. So they cause the least injury into the intima in these calcified vessels. So there's the other thing you can do. Choose a CC needle. That's called calcified coronary needles. So unless you ask for it, it's not usually available. So you should always have a bunch of CC needles in your armamentarium, because sometimes you may need those needles.
The only thing I am teaching them is, I don't know whether I'm right in doing so. I've been telling them, if there is an injury in a really damaged vessel, it is good to call a vascular surgeon. That is probably one vessel a general surgeon should not be repairing. Do you agree with me on this?
Absolutely. If this is the only it's a one-shot repair.
Yeah.
So unless you are very sure, you shouldn't be doing this. But it's a good idea to start vascular suturing in elective situations with a senior surgeon or senior surgeon in attendance, so that when there is an emergency, you are in a better shape to repair those vessels. Absolutely, I agree on that. Only other thing, Ilango, I would do slightly differently is, whenever you have a vein getting anastomosed to the artery, my arteriotomy would be at least 30% bigger than the venous diameter, 30 to 50% bigger than the venous diameter. You mentioned 10%. I would do 30 to 50% bigger, because vein looks much smaller. Once you start suturing, they expand. So my arteriotomy size would be almost 50% the size, 150% of the vein size. That's the only thing different I would do.
Yeah.
Ilango, there's an interesting question, the last question by Rajendran. He says, isn't it that the sutures during the final knotting should be on opposite sides and not on the same side?
Not necessarily, Dr. Rajendran. This is again a lot of variation between the surgeons, but I have used them on the same side for these 6-7 years. It actually has no value. You can suture it. It doesn't matter. If you suture it from either side, it looks aesthetically a little more pleasing. But for me, this has worked every time. So I have not changed it. I have been teaching this the same way for all these years. It's okay to do it like that. Okay. We are starting. We have already done 43 minutes. So I think I want to start the next video. This is a modified Telus technique, which I started using in AV fistulas. So I want you to start watching the video while I describe this. Again, this is an end-to-side anastomosis. The first bite starts in the middle of vessel 1. Okay, so there's a specific way in which I do it. Go by the first suture, goes to the opposite side. And this is a technique I believe can be done in the absence of a good senior assistant as well. So watch how I take the needle. Okay. All right. It sits perfectly. I picked this out of an old vascular surgery book, and it has become one of my favorite methods. So the orientation is how, so one has to stretch this. This is 2 ovals. And just watch how I'm suturing. So you start on the lower end. Good bites. So the biting technique, I mean, it's just over and over again, not locking. So that's the key. So watch me, I'm not twisting the vessel much. All that is required is adjusting your needle. However you place the suture in a Telus, it will always sit perfectly. So another key trick which I do, which I was not able to show here, is to mark one, either the 6 o'clock or the 12 o'clock on the vessel, so that you can exactly orient the vessel. So this is very, very important in vascular anastomosis. So this is a dried vessel. This is preserved vessel. So the whole vessel became dry in a short time. So got that? It sits well. So you have touched the corner. If you have exactly marked it, you will see the corner marking at this spot. So your corner is hitched. You can go one more round around the corner, get out, before you start the other side. Okay. So once that is done, you can short the vessel and you can start the other side. Now, there is a way to take the needle on the other side. Just watch it. I will explain. So I'm just passing the needle in reverse, just like how I would do a suture. And you can easily, you just saw me tilting the needle so that I can adjust the needle to exactly where I want it. Now it's very simple, actually. It just is running over and over. There's a way to take it. The angle goes towards the head end, okay? The bite on the end wing goes, all right, towards the head end side. So just do it over and over again. Very simple to follow, quick to learn. It was a very, very simple technique for me to just pick it out of a book. And I think I've used it in over 100 surgeries. So this becomes second nature. It will be the same for everybody. It's an old technique. So, but still very, very useful technique.
Okay, there are two questions, Ilango.
Yeah.
Dr. Tawhid Ahmad is asking, are you doing a double needed suture for this method?
Yes.
I guess the answer is yes. Right? Answer is yes.
Yeah. All needles are double needed. All vascular anastomosis, we never use single needles.
Okay.
Where do we use single needles, Pari? I don't think so. We use single needles. Probably to suture holes. Sometimes we may use single needles.
So earlier there was a question from Georgia, Dr. Lado Kostova. She's asking, during renal vein anastomosis in Georgia, at first we suture renal vein wall to iliac vein, in, out, out, in. So suture line is in the lumen of the anastomosis. Outer layer, just like you did. I am not very sure what was the impart in the question. Does she means that the suture, the knot is inside. I'm not really sure, but I
Knot
guess
cannot-
that's exactly what you did, right?
Yeah,
In, out.
yeah.
Only thing is we do it out in first. I think the doctor means in out as the first one, which probably is not a good idea, because then there's you have to put the knot inside, or you have to come out anyway and then knot it. So you have an answer for that? Would you start out in or in out?
I'm not able to exactly get the details.
She can unmute and come in and ask a question. That be clear.
So on the video, please watch that we are turning the corner on the upper end as well. So once do that, just ask the assistant to actually hold it up to the roof.
Yeah,
that's all is
just hold on, Ilango, but she has come.
Yeah, sure.
Yeah, what is the question, please?
Dr. Lado Kostova.
Dear colleagues, thank you for the chance that you did give me. So my question is like that. When we are suturing the transplant vein to the iliac vein, first of all, we are making the fixing sutures, and then a suture line pass through the lumen of anastomosis, not the node, but suture line, as in this video. And can it be rise the chances for thrombose formation?
No, it does not change. I think what you're describing is pretty much what we did.
Yeah.
We just take it in one portion of the line, vein, whichever is comfortable for us. That's all. I think the technique is this. What you're doing is probably slightly different. We cannot leave the knot inside the lumen at all.
Yes, of course.
No. I think I get the question. Dr. Kostova, I guess you're asking that you are going to be suturing from inside the lumen, right?
Yes.
That's absolutely fine. I do it all the time. That's absolutely acceptable.
Can parachute technique be used in renal vein anastomosis?
Sure. You can. The Pari is extremely fond of the parachute technique.
Yeah, I do it very often.
Thank you for your kind attention.
Sure, you're welcome. Another good question, Ilango, you want to take it?
Yep.
What if the circumferential lengths of two holes on the respective vessels are different from each other?
I have to read the question, sorry.
Yeah, what is the size of the vessels are different?
Okay.
What do you do?
What if the circumferential, for an end to side anastomosis, it hardly matters. For an end to end anastomosis, there are quite a few number of techniques, which I think we will be teaching in the next class. So that right now, I think we will miss the end to side anastomosis. So let's learn this first. And then I will tell you how to do the end to end anastomosis in the next class. For an end to side anastomosis, the difference between the two circumference of both the vessels actually does not matter. Okay. Okay, so once you hold it up, you will never backwall the vessel. So the only thing that the assistant has to do is to hold the suture really vertical. And I finish off the suture line. You just watch how I'm taking the vessel. I'm taking the bite through the same spot. Pretty much the same spot. I'm coming out. So I've just made it easier for me to suture. All right. And now you can just do a forehand suture quite easily. Watch, I'm not holding the other, just the vein towards you, vein of the vessel which is towards you, splaying open the gap. Just complete with the simple forehand suturing. Just it's very difficult to actually backwall the Telus anastomosis, especially when you hold the suture high up. One advantage of learning in the laboratory is that you can assess your anastomosis by cutting the vessel at the end of your anastomosis and checking the intima. So if you do that sufficient number of times, you will gain confidence to do the surgery. In surgery, obviously, we cannot do this. So here we are, perfectly done, spokes in a wheel appearance on both the sides. So this is a very, very simple technique to use. I'm just cutting the anastomosis and showing you. Okay. Okay. The anastomosis sits perfectly inside. So this is one advantage of learning and doing things in the laboratory. You cannot learn everything like this at the bedside. So if you get an opportunity like this, it's a big gift. All right, so good bites. This is the Telus technique. So I think we stop. This is not taken at speed. It's about 14 minutes. So let me share the next video.
Ilango, there is a question.
Yeah.
From Dr. Hitesh. What about the heel and toe suture? Heel and toe suture first and then suturing back wall from inside.
That's also perfectly possible. So especially if it is at an angle, you can do that. There is a slightly different method. What I thought was, what can you do very easily? See, there are multiple ways to skin the cat. Obviously, everybody will have their favorites.
I think this is
what we want to remember. This is what he's talking about is like the parachute, but you fix the toe and then take it, just like how I do the regular renal artery anastomosis. So that's one technique he's asking. We have not recorded it. Let me pull the.
I guess this is the same what our friend from Georgia asked. I guess it's been answered well. There's one more question from Dr. Tawhid Ahmad. So in the second technique, we have only one knot, and that's at the end. While in the first technique, we have 3 knots, 2 at the ends and 1 at the last.
The first technique had 4 knots, 1 at the 12 o'clock, 1 at the 6 o'clock, 1 at 3 o'clock, and 1 at 9 o'clock. It's a quadrangular suturing technique. So you have 4 ties in the first method, 2 in the second method. I'm going to show the third one. I'm just about to pull this out.
And one more comment. gut anastomosis, mucosa inversion. Vascular anastomosis, intima is everted. Is it correct?
Yes. Can I share? Okay. This is the parachute technique. I'm just trying to adjust it. Okay. For the parachute technique, something basics. So we have cut the vessel obliquely. We have marked the heel and the toe so that you can easily orient yourself. We've used the same anastomosis. We have made a longer cut. I think the rule which Pari says about 30% cut for a vein to an artery is very true in these circumstances. The oblique cut and the correct orientation is very, very important. So there is a slight difference between the parachute. Normally, if you look at YouTube videos of parachute technique, they use the U-stitch. I found it a little cumbersome for me to backhand every bit. But if there is a bad vessel on the straight one, or if this vessel is bad, you can see my marker moving, then under those circumstances, I would use a U-stitch because the intima will be properly hitched. In good and healthy vessels, this is how I do the parachuting technique. It's a little easier for anybody to learn. So let's start. So I have taken an inside out, and the first suture is to the heel of the anastomosis. So he's showing it. All right. And I take the thread under. Okay. All right. So I have brought it under. The penultimate suture is the one which is very, very important to place. You have to plan it and properly place it. I think, yeah. So you have to secure the that corner very well when you take the anastomosis. So this is much more simpler than the U-stitch. Both the vessels are kept apart, and so why do you think it's important for the students to learn the U-stitch?
U-stitch for the corners?
Yeah. Because I wanted them to learn a technique which they can use under emergency circumstances that looked a lot cumbersome for anybody to learn in the first phase.
Yeah.
That's why I made it very simple.
Yeah. The most important thing is the simplest thing only will work. So whatever is the simplest to be done.
Yeah. So this one is quite simple. You just have to go over and over again.
So there's a question, Ilango, you want to take from Dr. Patil. In the end-to side anastomosis, how do you decide the size of arteriotomy?
So we discussed this a little earlier.
I guess we discussed it.
Yeah, 10% for if you're doing vessels, and there was a good suggestion from Dr. Pari. If you're doing to a vein, you make it 30%. 30 or 50%, Pari?
Yeah, at least 30% to 30 to 50%. I give bigger arteriotomy. If it's a vein, if it's an artery, I give at least around the 25% bigger arteriotomy. Not more than that, 25% to 30% bigger arteriotomy if it's an artery. And then there is one more question from Dr. Pramil. Is there any change in the direction of suturing according to the direction of blood flow?
You don't have to match your suturing to the blood flow. But the angle in which you form the anastomosis is very, very important to reduce the eddy currents. But the suturing actually has nothing to do with your blood flow. As far as I know, that it doesn't have any impact. We are actually connecting two blood vessel walls. We are not doing anything to change the flow. But what is very important is angulation. That is why we spatulated, we obliquely place things so that the flow is appropriate. You cannot go against the jet. When the blood flow hits the wall repeatedly, it will damage that intima in the future. You might get away with the anastomosis. So you have to see how the lie of the anastomosis should be properly done. So I just watch me. I'm just going to tighten it. So that's what I wanted you to learn. So small jerky movements, the anastomosis will tighten. It's good to have a right angled forceps with you. See, it'll sit perfectly. You don't have to you don't have to struggle at all. It will sit perfectly, and then you will be able to complete the anastomosis. Even with extremely thin vessels, this will work. One has to watch cardiac surgeons when they do the parachute. The small jerky movements will actually tighten the suture. Don't try to pull it all at once. It may enlarge needle holes. So small jerky movements, you will get it corrected. So I felt this is the simplest parachute technique a general surgeon can actually learn. It's very easy for you to do even your first anastomosis by just looking at this. So that's why I did teach you the U stitch.
So in one of the future sessions, we're going to have a cardiac surgeon doing a coronary bypass.
Yeah, sir.
And also another surgeon do a cerebrovascular suturing.
Oh, that's great, actually.
Cerebrovascular vessels, yeah.
So it's good when you're young. It's good to watch a lot of surgeons, because each one of you will teach you some small modification in technique, which will help you in your career at some point or the other. So don't despise that. I don't want to become a cardiac surgeon and things like that. The good things you can learn from any surgeon. No, this passing the needle I learned from laparoscopic surgery. It has nothing to do with vascular surgery, but I remembered this, and I found it useful when I started doing the Telus technique on a regular basis. So I've been using it, but I actually learned it from a laparoscopic surgeon. So just follow every surgeon. Every surgeon you can learn. Okay, now watch this. The simple way of loosening the suture. You can use the needle. I have locked the suture and I'm correcting it. Got it? You don't need any specialized instruments for this. So just using the needle in your hand, you can correct the mistake in your anastomosis.
Ilango, a comment here.
Yeah.
When I was learning, somebody suggested that I can start learning vascular suturing on a banana peel. So yeah, thin vessel is going to be something like how a banana peel will be. So
Correct.
It might be a good idea to start practicing your sutures on banana peels. If you have some suture material and the instruments at home, whenever you have time, you can put two banana peels together and try to suture them without actually cutting through. So that is the amount of force you got to use when handling these vessels. If the banana peel is cutting through, it means that you're using too much force.
Too much force. That's a good one. Now, what to do microsurgery, they invariably stretch a glove on a small round ring. so that the glove is pretty much stretched. That gave me an idea. What we used to do is we could not get vessels when we were in training. So once in a while we'll get the grafts. But the simplest thing which you can do, practice fine suturing, is to use your regular gloves. So that is thin enough. That also will give you the same feel as a banana peel. I agree, bananas may be easier for us to get and get that right feel about the tissue.
We used to collect the leftover suture materials after anastomosis, and with the head nurse permission, we used to take them home, the leftover suture materials, and try and do it on those banana peels. So it may be a good idea to start doing it at your room in your own time, so as to get a good idea about how the feel is going to be when you actually do it on the blood vessels.
That's a good idea for young surgeons to follow. There is a tendency to think that all surgery is learned only on the operating room, which is absolutely wrong, at least in my opinion. You have to learn part of it in the operating room, and I think you can practice these skills in your room and bring them to fruition in the operating room. So, like if you have noticed, there is nothing actually magical about it's just a running suture over and over again. Just very simple. The vessel orientation and how you select those initial sutures are the only things that matter. So,
Ilango, there's one other question
yes,
by Dr. Ashwini. Suppose a suture has been wrongly placed. Do you suggest taking the needle out? How to correct a wrongly placed suture?
So you can take out the needle, but you have to, you cannot randomly pull it out. Sometimes it will avulse a portion of the vessel. So you have to follow the same trajectory as to how you put it. But if it is an interrupted suture, just cut the suture. It will save you a lot of trouble. Have I answered the question, Dr. Ashwini? Pari, do you agree with Dr. Narayan Kabadi's comment that the direction of the needle movement should be in line with the blood flow?
No, I don't think it matters at all. Okay. What matters is try and avoid making a 90-degree anastomosis.
Yeah.
So what you have to do is you shouldn't give a 90-degree anastomosis. There's going to be a lot of turbulence, and then it leads to intimal damage and then clotting. So what is important is you should try and give a anastomosis vessels which anastomose at an angle, not like this. So cut obliquely so that they sit like this, not like this. So that is what is important. Whether the suture goes from this end to the other or the other way, it doesn't really matter. Avoid a 90-degree anastomosis. Here, if you see, Ilango had made an oblique cut. So when the vessel lies, they should be at an angle. Yeah, nice, smooth, angle, not 90 degrees. That is what is important. I got one more comment, Ilango.
Yeah.
Can I?
Yeah.
So when the when people start making anastomosis, vascular anastomosis, I'll let you know the biggest problem I faced. The biggest problem is we are not able to take a precise bite. It is too big because we are all used to taking big vascular bites on the bowel and everywhere else. So it's too big. We don't get a precise small bites. So the important thing to know is, one, you have to have a very, very good positioning. You have to have a very comfortable position. And then if you see, we have got 4 or 5 joints here: shoulder, elbow, wrist, and then these joints. Try and stabilize as many joints as possible. Keep your hand like this, not like this. Then it shakes. So stabilize as many joints as possible. You keep the hand like this, elbow, if possible, rest it somewhere, and then rest as many joints as possible and make all the movements with the finger. Here in vascular anastomosis, you don't need the movements from any other joint. You don't need to take a bite like this. You don't need to pronate. What you need is you have to make movements only with the fingers. Stabilize as many joints as possible. Rest them somewhere, maybe on a table or over a folded towel or over a assistant's hand, wherever. Rest as many joints. Then the sutures become much more precise,
Precise,
more you
precise.
get a less tremors and then more precision in taking the sutures. That is one thing we probably can ask the younger surgeons to start learning.
Yeah. So I'm cutting the anastomosis. For you to see. The last question, there's a question from Dr. Tawhid. Is there any chance of getting purse stringing? Yes, if you put a slip knot, you have a risk of purse stringing the anastomosis. That may lead to a decrease in luminal circumference. So your first throw must be a squared one, the second one slip, and the third one squared. And then you can put whatever you like. But it's very important to square the knot. Pari, your comment on that?
Yeah, that's very, very important question he has asked. Couple of things. One, when you do this continuous anastomosis, when you tie it, there is going to be a purse string effect. That is the reason why when you're doing a vein to arterial anastomosis, we give a bigger cut, at least 50% bigger than the vein itself, so as to set off, offset some of the effects of purse stringing. Few other things what we can do is tie at the corners, so that you don't have reduce the purse stringing effect. Tie at the corners, then reduce the purse stringing. Or what you can do is when you're doing the vein to vein, we always give we don't tie the suture tight. You give us something called a growth factor. You leave it little, sort of you give a small air knot so that it will expand and then it will tighten itself. Other thing, when you're doing with the artery, when you're doing anastomosis with the artery, other thing you can do is slightly release the distal clamp in the artery, allow it to bulge a little bit, and then suture the ties.
Right.
Again, it will also reduce the purse string. So that's a very important thing. If you do a very, very tight knot, especially if you're taking very thick bites, there's going to be a purse stringing. That's the reason why we give a bigger arteriotomy. I said 25% bigger. Vein means 50% bigger arteriotomy, because to offset the purse stringing.
So like I summarized last time, these are things I want you to remember. Keep the setup ready. So instruments, magnification, all those things are very, very important. We have summarized what you would actually require in a small place. If you are not ready, please call for help. There are lots of seniors who can help you with vascular surgery in any part of the world. I think the first few vascular surgeries that you do should be to close holes in veins and sometimes in arteries, or when side branches have been avulsed. So the key thing is to get the stay in place. So when you start suturing from the 12 o'clock position, put a stay in the 6 o'clock position as well, so that you get the hole correctly oriented and the sides are approximated. So this is a simple way to learn to close the hole. So get a stay in 6 o'clock and start suturing from 12 o'clock. For an end-to-side anastomosis, get the orientation right and the angle right. So like what Pari summarized, don't do the anastomosis exactly at right angles because you're going to create a lot of turbulence and eddy currents. So my suggestion is see the flow and then get the angle of the anastomosis perfect. For an end-to-end anastomosis, it is to get both the orientation and the diameters right, which we are going to discuss in the next class. Thank you. We can take any questions.
That's a good question, Ilango. Any difference in technique when you operate on children?
So in children, for most of the surgeries I have done, vascular surgery in children are those in association with liver transplantation. So for portal vein, we use an interrupted technique so that growth is possible. So that is the difference we do. Apart from that, I have no experience of peripheral vascular surgery in children. Pari, you have anything to add?
All interrupted. That's the difference.
All interrupted.
Never put a continuous suture in children, because the vessels are going to grow bigger and bigger, and then once the vessels expand, and if you are given a continuous suture, there's going to be a constricting effect, and then there's going to be a sort of a stenosis. So children means all interrupted. Even if it is a hepatic vein also, it's a huge anastomosis, still interrupted, or at least one wall interrupted. If it's a huge vessel like cava to hepatic vein, putting all interrupted sutures may take a lot of time, or at least do anterior wall interrupted. Posterior wall may be continuous. So if possible, all interrupted. That is what the difference in children is. How will you manage a bleeding spurt after releasing the clamps?
So the first thing is not to panic. Normally, if your intersutural distance is variable, you can have that risk. Some of them will open up and then cause. So always have a repair suture ready when you complete the anastomosis of the same suture which you have used for anastomosis, same suture size which you have used for anastomosis. The advantage is that you can take a blind bite, take an X stitch on that leaking area. Because the lumen is already filled with blood, you have no risk of taking the back wall. If the bleeding is extremely severe, you may have to reapply the clamp and then repair it gently. So small bleeding spurts sometimes may stop when you just pack them and wait. Only for large gush of blood, probably you will need sutures.
If I can add here, Ilango, with my whatever little experience in portal abdomen surgery, with those days, two things just happen. One is after the anastomosis, dry sponges are kept, and we need to go by the clock and wait for 5 minutes, 5 complete minutes. And actually, a lot of these little leaks used to, close up. And also, I don't know whether you reverse the heparin with protamine. I mean, I don't know whether you do in vascular surgery or that is not there anymore. Reversal.
The only time I have used reversal is when we clamp, when we use it is in donors, live donors. Apart from that, we have never used protamine reversal. Pari?
Yeah, so Patta sir has told a very, very valid point. There will be, seemingly significant bleeders once you open up after anastomosis. 99% of these things are all from the needle bite holes, and most of them will stop. So just put a dry gauze, mild pressure, and then just wait for 5 minutes. Most of them stop, or at least it becomes very clear from where it is bleeding. So once you see after 5 minutes, you get a good idea exactly from where it is bleeding, and it's easier to take the suture. Instead of trying to immediately take suture, you're not very sure where it is bleeding. I know it's all messy, and and you're also slightly panicky. So just keep cool, stay cool, put a gauze piece, and then wait for 5 minutes and then see. If it still bleeds, or if it's a spurter, then you can take a bite like what Ilango had mentioned. That's absolutely important point. And we don't use protamine, sir, nowadays.
Okay.
No, we rarely use any protamine to reverse the heparin effect. Some units do, I guess, but most of them wouldn't.
So there's a good question from Lado Costa. After an end-to-side anastomosis, for example, during an aortofemoral bypass, if we have bleeding from the cranial side, how do you proceed in these circumstances? you do not have a good space for needle movement. So that's a very good question for those who are technically oriented. So you have to forehand the suture from the femoral side blood vessel. That is the what do you call it? Okay, you can take it just like the femoral artery and then take it into the graft. So that will be the natural flow of the needle. So you can do that a couple of times. You'll get a good grip as well as a control of the bleeding side. I don't know how to explain this without a diagram. This is quite easily doable, even in a very small, narrow angle. If you take the bite through the lower vessel, you can easily get it up into the upper vessel and then control yourself. So that is that's the technique for doing surgery in a very small space. Dr. Jacob John, for a free flap anastomosis, do you perform interrupted or continuous sutures? Sorry, sir, I'm not a plastic surgeon, so I have not done any free flap anastomosis. So
yeah, we'll be dealing with it in one of the later classes.
Later class. Would you use hydrogen peroxide to monitor for bleeding after release of the clamps? No, we have never used. I'm not sure how it's going to be useful. I really do not know. We have never used it like that. So thank you.
I think we've been about 1.5 hours, and it's very intense and focused teaching, Ilango, and I'm sure a majority of the audience has stayed on till about 1 hour 10 minutes, and today we have more than 100 people watching, and that's a very good credit to your teaching. And and there's a very good interaction, and Pari has added is a jewel in the crown. He added a lot of interesting points, especially the one about resting the joints. I liked it very much. Actually, resting the joints holds good for any surgery, as a matter of fact. I've seen many people use it, putting their and suturing like that, even for bar anastomosis. Resting is a very, very, very important maneuver. I think a lot of points, very valid points are learned today, and relevant for every surgery. And again, you got one more session coming Monday, and it'll be winding up on vascular surgery. Right? And please do join us again next Monday at 8 p.m. Indian Standard Time. Thanks, Ilango. Thanks for the effort. The lovely videos, very well done. We all want all the lectures to have videos of that nature, so we can understand it very, very closely. And these lectures will be available in the YouTube channel, Learning General Surgery, in a week or two. Thanks, Pari, once again for being there.
My pleasure.
Thanks everyone for participating, and please become members of Learning General Surgery and participate in all the academic activities. Thank you so much.